cracking here? We have Chapter 15, Respiratory Emergencies. We did a little bit of talking about this stuff yesterday on Chapter 14 when you guys came in and we were working through that pseudo-respiratory case that turned into a stroke. We got a pretty good idea of respiratory failure. We got a pretty good idea of airway obstruction. And the first couple things we're going to talk about here are some anatomy and physiology. So somebody walk me through this, because this should be reviewed. The structures of the upper airway. I'll point to things on the screen and somebody tell me what they are. So what do we have right here? What is this arrow pointing to?
Nostrils.
The nostrils, yeah, the opening to the nasopharynx. As we get into that nasopharynx, we have these ridges right here. They're called turbinates. What is their job?
To warm and humidify the air?
Yeah, they assist with warming, humidifying, and filtering the air. The turbinates in the nasopharynx will actually make the airflow through your sinuses and through your nasopharynx turbulent. So it helps some of the particulate tumble out. It gets it in contact with all of that cilia and all the mucus inside your nose that keeps all of the crud where that crud is supposed to be and keeps it out of where it's not supposed to be, namely your lungs. Moving on down through the nasopharynx, we get to the back of this cavity here.
Oropharynx?
The oropharynx. Those two things come together at the hypopharynx. What is our main source of obstruction in that oropharynx?
Tongue?
The tongue. And what can we do to fix that problem?
Use an OPA?
Use an OPA. Good, good. Still moving south here, we have this important little structure right there that separates the trachea and the esophagus. What is it? And what does it do?
Epiglottis?
Yeah, the epiglottis. And what's its function?
To keep food and liquids from going down into the esophagus?
Yeah, it'll come down.
The trachea, the trachea.
Yep, I got you. It'll come down over the top of the trachea, it'll seal that off, and it will direct food and fluid down into the esophagus where it's meant to be, and it will keep that same material, food and fluid, out of our lungs, because our lungs don't like that. Moving on down, we have the thyroid cartilage. That's the little plate that you can feel in the front of the beginning of your trachea. And we move on down to the cricoid cartilage. What is the cricoid cartilage for? Those little rings that make up your trachea.
It's to keep your trachea rigid and keep it from collapsing?
Yeah, we're trying to give it some shape, trying to keep it from collapsing on itself, because otherwise it would just be a floppy tube like our esophagus, and that wouldn't work well for us when it comes to breathing. Warm, filter, humidify, nasal mucosa, olfactory receptors, and extends to the back. Perfect, perfect. As weird as this sounds, air that enters our respiratory system through the oropharynx is actually less moistened than air that comes in through our nose. This is the oral cavity is what we're talking about here, and it extends all the way from the tip of our lips down to the epiglottis. Moving on down, we wind up in the pharynx. This is where the nasopharynx, the oropharynx, and the hypopharynx connect. This is all the way down right to the top of the trachea and the esophagus respectively. And from there, we start working through the structures of our lower airway. We get into the trachea, we get down into those bronchi, we get down into those bronchioles inside the lungs. And where does this whole system end?
Lungs?
What part of the lungs?
The alveoli?
Yeah, the alveoli. Between the outside and those alveoli, is anything really happening? Are we
What happens
sustaining,
to
are we
alveoli?
sustaining life with any of that?
No.
Nah, it's just a tube to move gas. Um, until we get down to those alveoli, nothing of any real consequence other than that is actually happening. What happens at those alveoli?
Exchange of carbon dioxide for oxygen.
Yeah, so where does the carbon dioxide come from?
The cells.
The cells, yeah, product of cellular metabolism. How does that all happen? What's the process called?
Perfusion?
So perfusion is what's being accomplished. Diffusion is actually what's happening when the oxygen in the alveoli, that high concentration, senses the low concentration of oxygen in the blood that's near it, and the gases swap. And the same thing goes with carbon dioxide. Carbon dioxide is high in the blood at that point, and it is low in the alveoli at that point, and the carbon dioxide diffuses across that pressure gradient so that we can exhale all of that bad air, get the carbon dioxide out, and send along all that good O2 rich blood now back to which side of the heart?
Left.
The left, yeah, the left side of the heart is attached to the aorta and our arterial system, which is that side of the system pressurized or not as pressurized?
Not as.
The arterial side?
No, the arterial side is.
Yeah, the arterial side traveling away from the heart and into systemic circulation is under pressure. Remember, that's our systolic and diastolic. When the heart contracts, we measure systole. When the heart relaxes, we measure diastole. And as long as the cardiovascular and the respiratory system are walking hand in hand into the sunset with one another, everything goes well. Most of what we're going to talk about for the rest of today is when things aren't going so hot. The trachea ends at what is known as the carina. The carina is the lowermost portion of the trachea where it branches off into left and right main stem bronchi respectively. The left bronchi obviously goes to our patient's left lung. The right bronchi goes to our patient's right lung, where all of the nerves, all of the blood vessels, all of the bronchioles, all of the everything actually enter into and make contact with the lung is known as the hilum. That's where things actually start to enter into the lung. Those left and right main stem bronchi divide into secondary bronchi that lead to each individual lobe of the lung. Those secondary bronchi branch out into tertiary bronchi to go out into the farther reaches of that particular lung. They eventually become tiny little bronchioles that are now going out towards each individual alveolar duct. And those alveolar ducts are where those alveoli live. They become the respiratory bronchioles and the alveolar ducts, and that is where all of our alveoli start. So from the outside to those alveolar ducts and where these little grape-like clusters of alveoli live, no gas exchange takes place. And if no gas exchange is taking place, all of that is that 150 milliliters of dead space we had talked about before. These alveoli, their shape, their tiny little clusters and tiny little sacs is very, very important to their function. When we talk about emphysema in just a little bit as one of our respiratory conditions, we will talk about what happens to change the actual shape and the structure of these alveoli to make them less functional. The alveoli have these little grape-like consistency to them. Why do you think that is? What's the benefit to that?
More surface area.
Yeah, we have more surface area. If we have more surface area, that means that oxygen-rich alveoli has more room to have contact with those capillary beds, those pulmonary capillary beds that are oxygen poor, so we can actually have more gas exchange take place. The alveolar capillary membrane lies between those alveoli and the capillary. That is that one cell wall thickness that you guys will hear me drone on and on and on and on about how important it is for those two things to be so close together. Because the minute something happens that makes that small distance any further or any more difficult for that oxygen to have to diffuse across, our patient's going to start to exhibit some signs and symptoms of poor oxygenation, because it's difficult now for that oxygen to do something that once was very, very simple. You know, the gas gradient and the different availability of those two gases in our patient's blood used to just make that diffusion happen on purpose. But the minute that diffusion gets further apart, it makes it more difficult for it to happen. And we'll see with some of our respiratory conditions just the function of that. So we're looking at our lungs here. We have a left lung with only 2 lobes and a right lung with 3 lobes. That other space that makes the left lung not have as many lobes as the right lung is occupied by the heart. The right lung obviously has 3 lobes, so we call them upper, middle, and lower. And we only have upper and lower on our left side. What is the significance of those 2 pleura, the parietal pleura and the visceral pleura?
Allows the lungs to expand without rubbing against the rib cage.
Yeah, it keeps things moving nice and fluidly, nice and easy, so that way we don't have an increase in friction, because an increase in friction will generate heat, it will generate swelling and inflammation, and it will make breathing painful. Those two things have a potential space between them. They're really close together, but they don't actually touch. Until we have some issues going on and things get into that potential space, and then they start to rub. That pleural rub, that grating sound we heard when we listened to lung sounds the other day, that's going to be what we're hearing, are those 2 pleural linings sort of dragging across one another. And if you remember back to what that sounded like it should be painful, right? I think, Paul, it was you that said it sounded almost like dragging a rasp across wood. So you're like sanding something. And that's pretty legitimately what's going on, and a pretty good depiction of that sound. Then we have the diaphragm there, making up the most inferior portion of our thoracic cavity. What is the significance of our diaphragm? It's got a job, and it's got an important one.
To
The
let
muscle.
yeah, like lets all, if you need to breathe very heavily, it lets all the air, like, I don't know.
No, you were on the right track. So not even just breathing really heavily. Every single breath we take is pretty well resultant on the diaphragm doing its job. The mechanics of breathing, right? My diaphragm contracts and pulls downward and anteriorly. My intercostal muscles contract and also pull my chest wall anterior and expand it out. So I've created a negative pressure inside my chest. And in creating that negative pressure, gas is going to rush in and equalize off that pressure with the atmosphere. And in doing so, we've oxygenated our alveoli, which means we're hopefully oxygenating our blood. We've ventilated at that point, right? We've gotten gas from the outside to the inside. The next thing that has to take place is respiration. That external respiration that happens between the alveoli and those oxygen poor red blood cells. The oxygen diffuses out of that alveoli and winds up on a red blood cell and goes back to the left side of the heart to go down to the cellular level and have that diffusion take place in the opposite fashion now. Now the cells are oxygen poor, the blood is oxygen rich, so the oxygen diffuses out of the cell through the capillary membrane. It goes onto the cell and gets in, and energy, ATP, is created. And the carbon dioxide that was in a high concentration inside the cell comes out of the cell, diffuses across that capillary membrane, gets onto the red blood cell and dissolves in the blood and gets carried back to the right side of the heart. So that the next time we go to take a breath, my diaphragm pulls down and anterior. My intercostal muscles contract and expand my chest wall out. I create that negative pressure gradient with the atmosphere outside. Gas rushes in, ventilates, gets all the way down to those alveoli for the gas exchange and actual respiration to take place again. And wash, rinse, repeat. It just keeps right on going. So we talked about those pleural spaces being really close together, but not actually touching. Let's talk about some things that can collect in that space and cause our patient some problems. We have a hemothorax. So anytime we see hemo, what does that word typically have to do with?
Blood.
Blood. So blood, anybody want to take a stab at what thorax means?
Chest cavity.
Yeah, so we have blood in the chest cavity. More specifically, we have blood filling up that pleural space. So now we've taken that potential space, those two linings that sort of sit atop one another, and we have put something in there that doesn't belong there. And we have now made one of those pleural linings actually compress onto the lung, and that's when we'll start to hear that pleural rub we talked about. So what do we think? Hemo, pneumo. Hemo means blood, we already know that. What do you think pneumo means? If you had a pneumatic tool, how would it work?
It's air.
Air, that's what pneumo means. So hemo-pneumo means we have air and blood collecting in that pleural space, and we're going to have much the same issue. Those pleura now, instead of being where they're supposed to be and being close to each other but not actually touching and able to help the lungs glide by one another, they don't do that anymore. And we start to see some irritation, some inflammation. If we're having those types of issues, irritation, inflammation, what do you think a patient's complaint might be?
Pressure.
Yeah, we could have some pressure. What's
They
something else they might say? What might they be feeling?
shallow breathing
So we might see some shallow breathing. Why do you think that they're making themselves breathe shallowly?
because they
Pain.
can't get enough. They can't get enough carbon. Well, they're getting too much carbon dioxide out, so they can't get enough oxygen in.
Not quite.
Sorry.
So, no,
Because it
don't be
hurts.
sorry. Because it hurts. Yeah, let's operate. Everything doesn't have to be this big, long, drawn out, confusing thing. If you have something that is irritated or inflamed, let's say you cut your finger, chopping something for dinner, and it doesn't heal real great, it becomes infected, and you get that red bit to your skin, and it really hurts a lot to touch it, or it hurts if you move it. That is a result of irritation and inflammation and that infectious process being in that one particular area of your body. So if we have irritation and inflammation somewhere, and that something, in this particular case, our lungs, is going to still continue to have to move all the time, the irritation gets worse, the inflammation gets worse, and it actually physically hurts our patient to breathe. So Corey, you were right. They are going to take more shallow breaths. And if they're taking more shallow breaths, they're not really getting enough oxygen in. They're probably not really getting enough carbon dioxide out. And we do start to see some problems as far as gas exchange, maybe even possibly developing into something like, I don't know, some flavor of shock. So your answer was close, but sometimes just break things down to the actual nuts and bolts. If I had a joint or something that was inflamed and I had to every second of my life continue to move that joint, it would hurt like all get out and I would be tired of it. So I would try and only move it a little to try and limit the amount of pain that I was causing. Much like the heart itself, the lungs do not just steal from the blood that they are oxygenating. In order for the cells of the heart to actually get the blood that they need to function, they send that blood back to the heart, and then blood is received in the left atria, sent to the left ventricle, pumped out through the aorta, and then the bronchial arteries actually bring that oxygenated blood supply back to the cells of the lungs so that the cells and the tissues in the lungs themselves can receive that oxygenated blood, have that internal respiration take place. So we have the oxygen-rich blood in the bronchial arteries and arterioles and capillary beds. The cells are oxygen poor. The oxygen moves from the red blood cells into the cells, and ATP is created, and the lungs continue to do their job. That's just the front half. The second side to that is the carbon dioxide now that was high in the cell moves into the blood itself that was low in carbon dioxide, and the bronchial veins will now return that oxygen poor, carbon dioxide rich blood back to the right side of the heart. The right side of the heart receives it in the atria, sends it to the right ventricle, pumps it out through the pulmonary arteries back to the lungs so that we can breathe off all that CO2 and byproduct of cellular metabolism that just happened. And then we take another breath in. We replace all that carbon dioxide with oxygen down at the alveolar level, and life is good. Air goes in and out, blood goes round and round. Any deviation is bad. So what would you guys say about normal breathing? What do you know so far about what we would call normal breathing?
Not labored. Just you don't even think about it.
Awesome. That's perfect. So yeah, not labored. What else?
Good air exchange.
So good air exchange. How would I be able to tell that?
Skin color.
Okay, skin color, temperature, condition. There's something else I could do.
Are they conscious?
Are they conscious? So yeah, their mental status. So now I've looked and I've sort of felt, because I got my skin color, temperature, and condition. How would I listen to button all these things up in a nice tidy little bow and be able to say that my patient's breathing was normal?
Lung sounds.
Lung sounds. Malachi, thank you very much. Give that man a cigar. We're going to listen to lung sounds and actually be able to hear that gas passing through the structures of our lower airway, passing through those bronchioles, getting down to the alveolar level. And as long as we have a sufficient rate, a regular rhythm, and a good quality, so a patient who isn't complaining of it hurts to breathe, isn't breathing so shallowly because they're having pain when they breathe, I can say that their breathing is pretty well normal. So I add into that the whole noiseless, effortless, and painless bit. And once I've evaluated those things, even without truly counting a respiratory rate, I can say that my patient's breathing is normal. So inhalation. Let's have a quick peek here, and I want you guys to tell me, is inhalation an active process or a passive process?
Active.
Active. How come?
Because the lungs have to, the diaphragm has to expand and the lung, chest cavity has to expand to create the vacuum to suck in the air.
Yeah, so I'm using muscle energy to make this whole process happen. So that is why when I'm creating that negative pressure, by making my chest wall and the internal diameter of my thoracic cavity bigger, it is an active process. It requires me to do. So what about exhalation?
Passive,
All right, same question. How come?
because everything is just relaxing to force the air out. So
Bingo.
you're not working at it.
Yep, I am not forcing anything to happen. As a matter of fact, those muscles are all just taking a powder. They are taking a second off in order to now decrease the size of my thoracic cavity. The lung recoils and shrinks back to its resting state. And when it does that, it forces out all of that carbon dioxide and all that water vapor. And from there, we had a passive process occur, and no energy was expended, and we're just on about our business. There are some respiratory conditions that we'll talk about in just a few minutes, where now our patient is so ill that inhalation and exhalation both turn themselves into an active process. And if we see somebody who is now taking what should be a passive process and making it cause work, what's something you might see in terms of their respiratory rate, rhythm, and quality or effort?
The effort will go up
The effort will go up. How come?
because they have to work twice as hard.
They have to work twice as hard, and they're recruiting muscles that aren't used to carrying that workload. And if those muscles aren't used to carrying that workload, they're not going to be in shape for it. So what are they going to do?
Fatigue.
They're going to fatigue and tire out a lot quicker. And when they start to tire out, that doesn't mean that they're off the job. What it means is they're going to demand more oxygen, and they're going to demand more glucose. Do we see this as a self-limiting solution to the problem?
Robbing Peter to pay Paul.
Absolutely. They are taking oxygen out of one pocket and putting it in the other. If the problem already at the beginning of this whole thing is I feel like I can't breathe, and then I'm recruiting these accessory muscles, and I'm making muscles that aren't used to doing the work do the work, and I'm forcing them to do it. And then I'm taking a passive process and making it an active process. I have now increased the work amount. I have increased the oxygen demand. And in doing so, maybe for a short period, I've somewhat worked the problem out a little bit. But sooner rather than later, that increased oxygen demand gets to a point where my shortness of breath, my respiratory distress, my rate, rhythm, and quality start to feel the pain a little bit. The noiseless, effortless, and painless part of it goes right out the window because it becomes noisy, or at very least, it becomes a whole lot of work. And we start to see a patient who is really not holding their own anymore because they have taken their their passive process and made it active and just doubled the amount of work that's happening. So now, what would you call abnormal breathing? Throw some descriptors at me. What would make something look or seem or sound or feel abnormal?
Wheezing.
Okay, so we might hear some wheezing, sure.
Strider sound.
So that stridorous sound, yeah, or the other side of that, because stridor's on inspiration, we may hear some crowing, so some upper airway obstruction on exhalation. Cool.
Gasping.
Gasping, yeah, so increased width between breaths or problems with the regularity, so we're not seeing that nice and regimented marched out respiratory pattern that we expect. Now it's a patient who breathes and then stops, and then maybe breathes again a few seconds later, and then stops for an extended period of time. So we'll start to see some problems with that whole rate and rhythm. We'll start to see some problems with our quality if we're hearing adventitious noises like wheezes. What are some things we'll see?
See, maybe them sitting in the tripod position.
Yeah, and we'll talk about that real up close and personal here in just a couple minutes. But we already mentioned it once. What's another change that we may see in this patient that will tell us that the respiratory system and the cardiovascular system aren't playing well in the sandbox together anymore?
Skin color.
Skin color, temperature, and condition. It all circles right back to this whole process is taking place in order to supply perfusion. And if my respiratory side of all this becomes unmanageable and starts to not work up to snuff and do the things that it's supposed to be doing in the way that it's supposed to be doing them, we're going to wind up with a perfusion problem. So yesterday when we did the shock lecture, tell me what some signs and symptoms of hypoperfusion or a lack of perfusion might be.
Cyanosis.
All right, we'll see some cyanosis, especially the sicker they get, the bluer they get, sure.
Maybe diaphoretic.
Yeah, they're going to start to sweat because it's becoming a whole lot of work and we're having a whole bunch of issues going on all at once.
Cold, cool to the touch.
Cool to the touch. What about mental status?
Start to become confused.
Yeah, we're going to start to lose our mental status. We're going to start having respiratory compromise, circulatory compromise. So these are all things that we can see and really hang our hat on the fact that our patient is having some abnormal respiratory problems causing their perfusion issue. And now let's look at this bottom bullet point. What do we think about filling of the alveoli? There's two sort of things we can discuss here. First of all, let's talk about the alveoli not filling.
Well, if it's not filling, there's not getting any CO2 carbon dioxide exchange.
Right. So what is something, again, that we can look at and say, boy, this isn't happening appropriately, and I doubt they're getting any gas down to those alveoli.
How fast the rate that they're breathing.
So sure, if they're breathing too fast, we're going to see that something else isn't happening adequately if their respiratory rate is just out of sight high. And we talked about it in CPR. We've talked about it every single time we've picked up a BVM, and that something is chest wall motion. If my patient is breathing 44 times a minute and I'm seeing the chest wall move hardly at all, it's pretty easy for me to decide they are not getting gas down to those alveoli and really filling up those alveoli with oxygen so that external respiration can take place. So how do I correct that?
Maybe assist them in respirations with a BVM.
Absolutely. That is one of those times where you hop right to your BVM and talk to your patient because they're probably still conscious and explain to them what you're going to do. And you'd be amazed once you start ventilating that person. Sometimes they do great. Sometimes they feel so much better, even with you doing something that is pretty aggressive and pretty sort of confining. They really will still do very well. Now let's talk about those alveoli actually filling with something that doesn't happen to be oxygen. What do you think they could fill with?
Fluids, mucus.
You got it. If we have fluid filling up those alveoli, is that oxygen-rich alveoli now only going to be that one cell wall away from those pulmonary capillary beds?
No.
Doesn't matter if it's fluid, if it's blood, if it's pus, if there is something in the way, that oxygen has to move through whatever that something is in order to get to that one cell wall, in order to move through that and get into the blood at the pulmonary capillary bed and get onto that red blood cell and be moved on about its merry way to go out into systemic circulation from the left ventricle and have that internal respiration take place now. So I told you there's about 1,000 different ways to check lung sounds. When I showed you the video the first time, it showed sort of different spots than I was showing you. Mid-clavicular above the breast, mid-clavicular below the breast, and then mid-axillary just above the last rib is really what I'm going to be looking for you for here in class. And it's going to give you, even as providers out in the street, it'll give you a pretty good idea of where you should be looking and where you should be listening. They are pretty much the same 6 spots on the back, so this would be in the same general vicinity, same lobe of the lung. This is sort of, we'll call it the posterior midclavicular line. This would be in the area of the apex of this patient's left lung, and then we'd get down towards the middle and the base of that left lung. And then on the right side, we'd have apex, middle lobe, and base of the right lung. Back lung sounds are a little bit more difficult to listen to, and the back is only the back of the front. So if you only listen to anterior, you're not hurting anybody or hurting anything. So next, we're going to talk adventitious breath sounds. Adventitious is just a $10 medical word that means bad. These are not sounds that we hope to hear. These are not sounds that mean anything really particularly great is happening for your patient. Crackles is the noise that we expect to hear when we have fluid, and really like thin fluids, we expect to hear crackles. So things like blood or just a buildup of plasma or anything else that's sort of a water-like consistency, we'll expect to hear some crackles, also called rowels if you know somebody like me that's about 100. From there, we'll talk wheezes. Wheezes are generally considered to be our asthma patient. We normally hear those on exhalation. It is air trying to move through those constricted airways. We have smooth muscle around that whole bronchial tree, and that smooth muscle will contract, and that is what will give us the wheezing sound. We will hear it on exhalation most of the time. If our asthma patient is really, really sick and constricted, we may hear it on inhalation or exhalation. And what this is a disease of I can't get gas out, and that's what we're hearing with the wheezes. Next, we have sort of a mucousy kind of gross sound called rhonchi. This is generally secretions in the upper parts of the airway. Normally, it's kind of a junky, gross kind of product of infection, something like pus or what we in the field affectionately refer to as lung butter. It's really just kind of gross, and you may hear this all the time, anytime there's air moving by, sort of this buildup of crud in your patient's larger airways, you may hear rhonchi. So we've played these sounds before, and I will play them again today when we come back into class. Now that we've spent a good deal of time establishing what is regular and listening a little bit to what is irregular, I'll try and fire up the mannequin and see if I can make some of these sounds actually happen for you guys for real. And maybe we'll play with some of the expensive gear today. But look at what's happening in this pulmonary capillary bed. What this is a picture of is it's showing you how gas exchange is impeded by that fluid. We have oxygen inside this alveoli. Then we have a small little river between the alveoli and this red blood cell that the oxygen's trying to get to. So the oxygen has a hard time diffusing across that. The carbon dioxide has a difficult time diffusing across that moat as well. And we don't really hear anything good happening because eventually those terminal bronchioles in the alveoli will actually have to be breathed open with each breath, and we'll hear that popping noise. The further up in our lung sound evaluation that we hear these noises, the sicker generally our patient is. Because if gravity is confining that fluid to just the bases of my patient's lungs, that means the upper 2/3 are available for gas exchange and breathing to take place. If I listen at the apexes and I hear these crackling noises, I know that my patient is packed almost to the top with fluid. Those are patients who are going to want to sit absolutely bolt upright on the stretcher so that gravity can actually assist them in breathing. And we want to let them do that and help them sit as upright as they can, because that pulmonary edema, that swelling and fluid collection around those alveoli, we need gravity to work with us and hopefully pull down as much of that fluid as it can, so that that way our patient will improve a little bit, especially when we apply to them some extra oxygen. We put on some oxygen. How are we going to give it to them here in the classroom?
Non-rebreather mask, high flow oxygen, 15 liters per minute.
Yes, sir. And then when we get out into the field, we're going to put on our oxygen and we're going to titrate it to effect. Start small, work big, and turn the oxygen up from a nasal cannula to a mask, possibly, and titrate until your patient begins to improve. How would we know that a respiratory patient that we heard crackles on was maybe beginning to improve some?
Sounds would diminish.
So yeah, the crackles would maybe get a little bit better. What else?
Their appearance, their skin tone, color, texture, temperature.
Sure thing. They're actually going to begin to look better. We may see that instead of now being pale or cyanotic, that they start to pink up a little bit and maybe warm up a little bit. Maybe their respiratory effort will decrease a little bit, and they will tell us that it's not as difficult to breathe anymore. And they might even just say, "Oh my God, thank you, I feel better." That's pretty straight in my book. I mean, if I do something to my patient and then they say, "Wow, thanks, I feel a lot better now," well, we're winning. We might still be involved in one heck of a fight, but we're winning. Wheezing, I think we covered pretty good. Again, I'm going to play these things for you today, and I'm hopefully going to get you guys the opportunity to listen to them with a stethoscope. I have to go fire up the dummy and cross my fingers and hop on one foot and write a check to the gods of Laerdo to make sure that he decides that he's going to do the things I ask him to today. And then this is the excess mucus, that rhonchi that we hear. So not only do we have a whole bunch of sludge down there causing our patient to have problems with gas moving and gas exchange, but all of that stuff that's down there, all of those thick secretions, are actually going to inflame that bronchiole. So it could be difficult or painful or just uncomfortable for this patient to breathe. All that irritation and inflammation, a lot of the times, will cause our patient to cough. It does sometimes make a bit of a rattling sound when you're listening to it, and it's really just kind of like a rumble, and it's really not really pleasant for you, and it's not really pleasant for your patient. This is someone who is either A, pretty sick, or B, generally chronically ill for a lot of the time. So you guys tell me some stuff about respiratory distress. What do you think would make breathing distressing?
Trauma.
So trauma could, sure. If there's not enough blood going round and round, it doesn't matter how well we're breathing, it's going to stop eventually.
An anxiety attack?
Anxiety, sure. So that's going to probably cause us a disturbance with which? Rate, rhythm, or quality?
All three?
Absolutely. It could be a problem with rate. Our anxious patient's going to breathe a lot. Rhythm, well, clearly, if we're looking at it and going, holy smoke, their chest is going up and down about the same amount of times as a hummingbird flaps its wings, well, that's problematic. And if we have a rate problem and a rhythm quality and a rhythm problem, clearly we're going to have a quality problem. I like it. What else?
Hyperventilating.
So, yep, we wind up with rate, rhythm, and quality issues again. So really anything that affects the patient's ability to get gas in, get gas down to those terminal bronchioles and the alveolar ducts and into the alveoli, anything that causes that gas exchange, so the external respiration to not take place, or even when we get down to the other side and we have problems with the internal respiration, we're going to have respiratory distress at least. And how quickly our patient summons help and how quickly we're able to assess and treat these issues is going to tell us how distressed their respiratory distress becomes, or do they eventually get to the point of respiratory failure and we wind up having to treat them more aggressively with a BVM or increased medications or being intubated and placed on CPAP and all sorts of advanced level stuff. But the body is picking up on these things. The body is looking at hypoxemia. So we'll break this word down. Hypo is low. Ox and emia. Ox is going to be oxygen and emia is blood. So decreased oxygen in the blood, hypoxemia. Hypoxia is low oxygen in the tissues, hypo, low, oxia. Dyspnea is the medical terminology for shortness of breath or difficulty breathing. Dys means dysfunction, pnea means breathing, so dysfunctioned breathing, shortness of breath, difficulty breathing, whatever your patient describes it to you as, that's what we're looking at. And then generally, anytime we see A in front of a medical term, it means bad. The A or an in front of any medical terminology means lack of. So apnea, pnea meaning breathing, and the A in front of it means lack of breathing. Our patient is not breathing at all. And if our patient's not breathing at all, well, that's a pretty easy leap for us to make. We pick up BVM, we hook it up to 100% oxygen, and we are going to ventilate this patient one breath every 5 or 6 seconds. Pretty simple, pretty straightforward. The shortness of breath one and figuring out distress versus failure and maybe some of the causes and concerns that come along with what is making this patient's respiratory status distressing is what we are going to talk about next. But we're going to shut it down for a couple of minutes because even though that was review, those are some high-level topics. So why don't you guys take a short break? We will come back in, let's see, what time do I want to put up here? I took a class not too long ago, and the lady said never give an even numbered break time. So people expect 10 minutes, give them 8, give them 7. People expect 15, give them 13. So I don't know why, but she was a smart lady. So you're off on your 8-minute break. All right, everybody, we're back and ready to get after it. So let's talk some signs of respiratory. Forgot to unmute myself. I was talking to nobody. Here we go. We're back and getting after it. We're going to talk signs of respiratory distress now. We can have a mechanical disruption to our respiratory drive and our respiratory quality. We can have a receptor problem in our brain or scattered throughout the body that will cause a disruption, or we can have problems with gas exchange. These are the things that are going to point us towards a problem with our patient's respiratory status. So a mechanical disruption is going to be anything that involves the airway, lung, or chest wall that prevents the actual ability of our patient to ventilate. This is going to be a patient who is not moving gas well enough from an airway obstruction, chest muscle problems, neuromuscular diseases, a pneumothorax that will lead to what kind of shock does a tension pneumothorax develop into? Does anybody remember? All that pressure is building up in our chest, can't escape, begins to squeeze on some of the important structures in there, the heart, the vena cava, and we
Cardiac shock?
cardiac shock, not so much. We're blocking blood flow returning to the heart when we have a tension pneumothorax. So if we're blocking it, it turns into obstructive shock. Stimulation of the receptors, that's going to be things like asthma, pneumonia, CHF. It's pretty much some form of internal type problem that is causing issues with our patient's respiratory status. And then we have issues with ventilation and perfusion that will cause our inadequate gas exchange. Now, ventilation and perfusion is something we'll talk about in just a couple minutes. So our respiratory arrest patient is generally led themselves through the progression of respiratory distress down into respiratory failure, and then the effort to breathe has become so much, and the body's struggle to adequately oxygenate itself and allow for perfusion has completely ceased. If respiratory arrest is not managed shortly after it begins, our patient is going to become profoundly hypoperfused because no oxygen is coming in. So within minutes, that lack of oxygen can start to cause brain death, death of the heart muscle, and eventually turn into cardiac arrest. And our patient will be pulseless and apneic, not just apneic. Whether our difficulty breathing is traumatic or medical, our first priority is to determine if our patient in respiratory distress needs oxygen therapy, or if our patient in respiratory distress is truly in respiratory failure instead, and it needs immediate ventilation with supplemental oxygen. So let's talk some pathophys here. We're going to actually study the diseases that cause respiratory distress. So I mentioned emphysema earlier, and I mentioned how it affects that increased surface area of our little alveoli. 300 million of them in each lung, crazy. Emphysema is an obstructive pulmonary disease. It's going to reduce the amount of airflow in the respiratory tract and that will lead to hypoxia. What we see with our emphysema patients is we have some breakdown in the walls inside those alveoli. I'll take out my little pen here, and I'm not much of an artist, so bear with me. And I'm going to trace around these alveoli, and you'll see how long it takes me to draw and trace every bit of alveoli here. We're covering a lot of ground. We're using up a lot of highlighter. Good thing it's on the computer. And I have finally made it to the end of just this little cross section of alveoli. Now, if I use the same thing and the same pace, I'm using way less highlighter and covering way less ground to trace around this damaged alveoli in my emphysema patient. So if I'm covering less area, I have less space available for that gas exchange to take place. Now, the most common cause of emphysema is going to be a patient who spent a lifetime inhaling superheated toxic gases through the end of a cigarette. And it will lead to the destruction of those alveolar walls. It will lead to a decreased surface area. The alveoli become destroyed and really aren't so good at doing their job anymore. And these are patients who have prolonged expiratory periods, so it takes them longer to exhale and get all of that trapped carbon dioxide out. And our emphysema patients, a lot of the times, are people who will turn the passive process of exhalation into an active process. And it means that they are actually now contracting their muscles to squeeze out as much carbon dioxide as they can, because carbon dioxide levels in our blood is what actually stimulates our respiratory cycle. Carbon dioxide stimulates us to exhale and blow all that away. That's that hypercarbic drive we talked about during chapter 6, the human body. That hypercarbic drive, a lot of the times, no longer works for these patients, and their respiratory cycle switches to a pathologic process called hypoxic drive. They are stimulated to breathe based on the fact that their oxygen saturation, the oxygen level in their blood, is low because of the destruction to those alveolar walls, the decreased surface area, and the decreased gas exchange on our external respiration. Generally, since they make exhalation an active process, they're going to have a thin appearance most of their body, but their chest is going to look jacked because they're using those accessory muscles. They're using additional effort and really working those muscles up to actually now shrink down their chest cavity, shrink down the size of their lungs, compress things enough to build up that pressure to force gas out. Our emphysema patient, a lot of the times, will be coughing a lot, but it will be non-productive. It'll be a dry cough. When they cough, very little will actually come out. No sputum, no chunky bits, no really much of anything. They will have a prolonged exhalation period. They are actually lengthening out their respiratory cycle in the period of exhalation in order for those extra muscles to come into play to try and force out more CO2. When you listen to their breath sounds, we're going to have some diminished sounds. They may be quieter, they may be more difficult to hear. We may hear some airway constriction, so we might hear some wheezing. We might hear some rhonchi. We might hear a little bit of anything when we put a stethoscope to this patient's chest. What do you think their complaint will be? Because we always get the respiratory distress, right? It's like 25% of our calls are respiratory in nature. Do you think it's going to hurt this person to breathe?
They'll be saying they just can't catch their breath.
Could be saying that they just can't catch their breath. They could be saying that they feel like they can't get enough breath. It's generally probably not going to be painful. If they've done something, so they've had some period of activity, they a lot of times will feel like they just can't breathe. It's not necessarily going to be more painful. It's not necessarily going to be more effort. They're going to a lot of times complain of, I can't get enough. So most of the time we can increase their inspired oxygen with some of our supplemental oxygen, 15 liters per minute by non-rebreather masks, because we're in class. And we will see them actually begin to improve a little bit. It may take a little bit of time, but we may actually, especially if we get to this person soon enough, so they activate 911 in a reasonable amount of time, we may actually be able to affect a little bit of a change. This is that barrel-chested appearance. If you look at this patient, you can see how stick skinny his arms and his legs and even his abdomen is. But if you look, the rest of his muscles required for breathing, his chest is pretty defined. He has those sunken in clavicle areas because he is just using so much effort to breathe that those muscles are getting ripped. When we talk about pursed lip breathing, this is something that refers to a patient who is what we call self-peeping. PEEP is the peak end expiratory pressure. When they put their lips together like that and trying to blow out through that, they're actually generating a pressure that is helping them get more carbon dioxide out. But we're going to hear them a lot of times say, you know, it's difficult. I feel like I can't get enough. They'll have a generally pink complexion. These are what we call, with that pursed lip breathing and our pink complexion, they are affectionately referred to in the field of EMS as pink puffers. Tachypnea, what does tachypnea mean?
Rapid breathing.
Rapid breathing, all right. What about tachycardia?
Fast heart rate.
Okay, good. And then we may see some diaphoresis. We expect that this patient will probably be on some home oxygen. And then this tripod position. This is a perfect picture of a patient sitting in the tripod position. This woman is leaned forward with her hands on her knees. Now, someone who's just having their average every day, not really looking like the most comfortable position to sit in. But someone who's having a respiratory issue sits like this physiologically. Their body just sort of instructs them to sit in this position. And what is happening when your patient sits like this is they are pre-stretching all of those muscles that we use to get gas in. So they are pre-stretching and priming their diaphragm a little. And the same with their intercostal muscles, because a lot of times they sit like that with their chest sort of poked out. So they are making breathing a little less effort because they have those muscles pre-tensed. This tripod position is like classic respiratory patient. For the most part, you'll see this in respiratory patients alone. And it really is just a physiological thing where they are sitting like that to make breathing less effort. Next, we'll move on to chronic bronchitis. Now, I'm sure people out there have at some point or another in their life had bronchitis. It's a buildup of mucus and some infectious materials and stuff down in the bronchioles, down in the lower portion of the airways. Not quite pneumonia because it's just a different pathology, and it is kind of just chunky and disgusting. Our chronic bronchitis has that same problem, but they don't get better. No matter how much they cough, no matter how much sputum and things they are managed to cough up and get out, that mucus production just continues. The airways will become thickened and swollen and inflamed all the time, which restricts the amount of airflow. And on top of that, the alveoli aren't going to expand fully, and the oxygen is going to have a difficult time diffusing through all of this built up crud on top of all that inflammation and swelling. So our patient is going to pretty much chronically be hypoxic and short of breath. The thickening and the swelling and the mucus production are really what caused this patient a lot of their issues. Anybody want to take a guess at what a pretty common cause of this might be? I know we're all going to be super surprised when I hit the space button. Smoking. Again, And again, this is another one of those spots where I say, do as I say, not as I do. Smoking is going to be a pretty main cause for our patient with chronic bronchitis. The alveoli are just being constantly irritated and inflamed, and soon enough, this is just something that happens all the time now, and it is just the way it goes. The airways will become narrowed, and the resistance to air movement will become more difficult, and it will be chronic difficulty breathing for this patient. Add to that now, we're going to fill those lower airways with all this extra mucus that no matter how much you cough and how much you get out, it just comes back, and your patient will wind up chronically short of breath. Their complaint all the time is, I feel like I can't breathe. These are patients that we expect to be a little bit blue. We may see some bluing around the lips. We may see some bluing in the nail beds the sicker they get. Even their gums and any of the other mucosal membranes may start to have a little bit of a bluish or cyanotic tint to them. This patient is going to be typically overweight. They're going to have that vigorous, productive cough. They are going to have a chronic complaint of difficulty breathing. It's going to increase when they have something like a respiratory infection or increased period of activity. We may hear, again with this patient, some coarse rhonchi, some wheezes, some crackles. It may sound like there is a 21-piece band playing in this patient's chest when you put your stethoscope to it. But their complaint will be chronic short of breath. They also may be on some home oxygen to sort of increase what's available to their body. The oxygen around us is only 21%. Every liter per minute that we add to that patient, so if we have 15 liters per minute, we're adding another 4% per liter. So we are giving as much oxygen as can be provided by increasing the percentage that's available for the body by giving them extra oxygen. So let's talk about what our emergency medical care is. What are we going to do for these patients? Shortness of breath, respiratory distress, emphysema, chronic bronchitis. Anybody?
Give them oxygen.
Yeah, we're going to give them oxygen. We can't fix their emphysema. We can't fix their chronic bronchitis. We can't fix their COPD. So we're going to give them oxygen. Just know that even giving them oxygen may not make them a lot better. When we go to recheck things like their O2 saturation, since they are chronically hypoxic, their O2 saturation may not go up as much as we would hope that it would, but we'll go right back to the patient. Hey, is this oxygen helping? If they say no, we turn it up some, and then we go and reassess. And then we ask again, hey, is this oxygen helping any? And then we turn it up some more, and we wait until we see that oxygen having its desired effect, and my patient says, boy, I feel better. And maybe their complexion improves a little bit, and they're no longer pale or cyanotic or diaphoretic. And we start to see them relaxing a little bit instead of working and struggling so hard to breathe. Anybody with a respiratory complaint is going to get oxygen. In class, like I've said at least 100 times, everybody's going to get oxygen, 15 liters per minute, high flow O2 with a non-rebreather mask. Years ago, with patients who had chronic respiratory problems, we used to worry about knocking out their hypoxic drive. I know you guys can't see me doing my air quotes, but that is not an EMS problem. An EMS problem is my patient can't breathe right now and they're hypoxic. So I need to give them some oxygen. When we talked about knocking out their hypoxic drive, remember that these people breathe dependent on a low saturation of oxygen in their blood. You and I breathe dependent on an increased level of CO2 in our blood. Our respiratory cycle begins with exhalation, not inhalation. A patient who has switched due to a pathological process to hypoxic drive, their body's respiratory receptors respond to a decrease in O2 rather than an increase in CO2 and stimulate them to take a breath in. We used to worry that if we put high flow O2 on a patient who had COPD or emphysema or chronic bronchitis, we would actually supply them enough oxygen to stop breathing completely, because their oxygen saturation would go up so astronomically that their body would say, well, we're not low on O2 anymore. We don't need to do this crap. How long are we generally with a patient, do you think, in an emergency situation?
Half hour maybe?
Yeah, like tops, right? That would be about as long as from the minute I got to their side to the minute I left them in the emergency room, maybe a half an hour. Knocking out their hypoxic drive is something that happens downstream. Patients who are on a high amount of oxygen for an extended period of time. We are not going to be with them for long enough to do that. That's just not going to be a thing. So my patient who needs oxygen is going to get oxygen, period. So now let's talk asthma. Somebody out there on the other end of this microphone, tell me what exactly is happening with our asthma patients.
They can't get air in fast enough. So they hyperventilate.
Well, yeah, we're going to see definitely an increase in their respiratory rate. That's for sure.
The bronchial passages are constricted.
Yeah, the bronchial passages is starting to constrict. We have those smooth muscles that wrap around the outside of those bronchioles to let them expand and contract as needed. So, you know, when we're running on the treadmill, they'll open up nice and big and wide, and we can get as much gas in as we need to continue running on that treadmill. Well, our asthma patient will have constriction of those bronchioles. Those bronchus, actually, that smooth muscle clamps down on them and makes the internal diameter of those passages very, very narrow. The bronchospasm comes along with some edema, so we'll start to see increased development of fluid inside of those same tubes that just shrunk themselves down. So now we have a decrease in the amount of gas that can pass through, and we have a pond in the way. On top of that, our body will start to form these mucus plugs here in the lower bits of the airway and close off entire swaths of alveoli to gas exchange. They won't be available. We'll have that bronchospasm, edema, mucus in the lower airways, and these are generally acute things that happen irregularly or periodically. Most patients that have asthma know what is going to trigger them to have an asthma attack, and we can fix this. You guys can assist your patient with their albuterol inhaler. Follow the recommended dosing. Generally, it's probably 2 puffs every 4 to 6 hours as needed. So hopefully before you get there, your patient hasn't hit that thing a million times, because most of the time when patients are using an albuterol inhaler, they're not using it correctly. I went over when we did pharmacology, how you're supposed to walk your patient through using that. You want them to take a nice deep breath, deep as they can, and then blow out everything that they just took in. Blow out, blow out, blow out, blow out. Exhale as much as you can. Then they take that albuterol inhaler and put it between their lips, and they depress the medicine, and then they take a nice deep breath and hold it. We are trying to get that medicine all the way down to this spot because we want to relax that bronchial spasm and that bronchial constriction. We want to open those airways back up with that albuterol. We're going to hopefully with that albuterol be able to dry up some of that edema and clear out some of those mucus plugs and reverse all of the things that are going on with this patient's asthma attack. Does it seem pretty reasonable that our patient's going to have some dyspnea or difficulty breathing? That our patient will probably be coughing, but it's going to be non-productive because there's really not a whole bunch down there that they're going to be able to cough out. We're going to hear those wheezing lung sounds that we talked about. Generally, when do we hear wheezing on our asthma patient, in or out?
In or both?
If we hear it in or if we hear it both, this patient is very, very sick. Because asthma, remember, is a disease of I can't get gas out. So we'll typically hear those wheezing sounds initially anyway on a patient while they're trying to exhale. We'll have some tachypnea, we'll have some tachycardia. You can expect some level of anxiety on any patient that is having respiratory distress, difficulty breathing, or any of the things that we've already discussed or will. Why does my asthma patient, though, complain of this very specific symptom? Chest tightness. Why is their chest going to feel tight?
Because they're not getting enough oxygen in there.
And they're not getting enough oxygen in because all those airways are closed. And all that gas has actually been trapped. And they feel that tightness because their lungs are filled up with gas that is no good for them and they can't get any more in. And they will actually stimulate the stretch receptors in their lungs because they now have so much of that cruddy CO2 rich gas down there that they can't get any more of the oxygen that's going to help them past all of that and past all of that constriction and past all of that spasm and edema and mucus plugs, except we can fix it. Albuterol is the beta agonist that we are going to provide for this patient. Beta agonist means it's going to get down to the beta receptors, the beta 2 receptors specifically, in those lungs and relax all of those smooth muscles and open up all of that constriction and dry up all of that edema and make it so that those mucus plugs will go away and our patient will be able to cough them out and get rid of them. Beta agonist medicines are going to be the standard for our asthma patients. It's what's going to help them the most. If we have tightness already in the chest and our patient feels like their lungs are stretched to the max, we really don't want to have to ventilate them if we don't have to, because it is entirely possible that when we go to ventilate them, we won't actually be able to force gas into them with the BVM. And we could cause some barotrauma to their lungs by actually shoving too much gas in through all of that airway resistance. So transport and reassess, and especially before and after you give your beta agonist medicine, that albuterol, reassess your patient after you've done it. See if they're getting any better. See if that chest tightness has improved, because that's the reaction we hope for when we introduce this drug. Any albuterol any inhaler that is not albuterol, we're going to not provide to our patient. Our patient may be on several different inhalers. They may be on inhalers that have corticosteroids that actually help them over time. They may be on all sorts of other inhaled medicines that we do not want to provide to them. So if they're not on albuterol, we don't give them albuterol, period, end of it. So now let's start talking about some patient assessment. Some typical complaints and some typical things we may see or hear is going to be some nervousness and anxiety. Not being able to breathe is definitely going to cause some marked anxiety in your patient. We may have a complaint of dizziness. Remember, the brain doesn't function well or really at all if it doesn't get enough oxygen. Well, shortness of breath or difficulty breathing, those are pretty simple. Our patient's going to tell us, I feel like I can't catch my breath. I feel like I can't breathe good enough. I feel like I can't breathe enough, period. It's difficult. It hurts. It feels like a lot of work. These are all things that our patient might tell us, and that leads us to shortness of breath or respiratory distress. That tightness, we beat that up pretty good with our asthma patient. They may start to experience some numbness and tingling around the mouth, some tachypnea, this carpopedal spasm. Remember yesterday, I think it was Corey, you asked about our patient who is hyperventilating because they were in that psychogenic shock, right? This was,
Yeah.
am I in the right conversation?
Yep.
Okay, cool. Specifically, this carpopedal spasm is what Kevin and I were mentioning when our patient's hands and feet turn into clubs because they have pretty much breathed off almost all the CO2 in their body and they are not going to be breathing so well. Our patient whose respiratory rate is ridiculously fast, we want to try some coaching because even if we put oxygen on them, once their respiratory rate gets to a point where we're concerned with how fast it is, they're not going to have the quality. They're not going to have that good expansion of their chest wall. And if they don't have that, just having more oxygen available is really not going to be helpful. They are going to wind up still every bit as sick as they were before we provided any treatment. So I hope all of this looks pretty familiar. Scene safety, BSI, EMS safety is first. We're going to start forming our general impression. We're going to assess our patient's mental status, and then we're going to move right through the rest of our primary assessment. Airway needs to be made open, clear, and secure. If it's not all three of those things, we need to do something to make sure that it is. Open the airway, clear the airway with some suction or some positioning, secure it with your airway adjunct of choice, OPA or NPA. We're going to assess our patient's breathing, rate, rhythm, and quality. We're going to assess our patient's effort of breathing. It should be noiseless, effortless, and painless. We're going to listen to our lung sounds. And then once we have determined that, yes, my patient does have a problem with breathing, we're going to supply our oxygen, 15 liters per minute supplemental O2 via non-rebreather mask. Then we're going to move right down to circulation. We're going to compare our either carotid and radial in an unresponsive or just our radial in a responsive patient. We're going to get our skin color, temperature, and condition. After skin color, temperature, and condition, we're going to make our transport decision. What is my transport decision for all of our patients?
To the nearest appropriate facility with intercept with ALS.
You got it. And then from there, I start working my way through my secondary assessment. I get my onset, provoke and palliation, quality, radiation, severity, time. Then I move into sample or sampler, signs and symptoms, allergies, medications, pertinent past history, last ins and outs, the events leading up to, and any risk factors. Now I have gotten nearly enough information. I'm going to get my set of baseline vital signs. I'm going to get pulse, respiratory rate, heart rate, probably an O2 saturation because this is a respiratory patient. And all of those things smushed together in a nice tidy little package are going to tell me, can I treat this patient with some more medicine? Or do I transport this patient and reassess every 5 minutes because they are a high priority patient. I'll listen to their chest a bit more. I'll inspect their chest a bit more deeply to make sure that I'm not missing some sort of mechanical problem. And on the way, I start right back at the beginning. I reassess my patient's mental status and general impression. I go right back through the ABCs. I ask them about the oxygen that I have given them. Is this helping you? Are you feeling any better? Maybe I have to turn the gas up a little bit. Maybe I don't. If I've given them medicine, after I've gotten through my OPQRST, my sampler, and my vital signs, I'm going to reassess the treatment. I want to make sure that the treatment I have provided for this patient is working the way that I had intended it to. And then by the time I'm done doing all of that, we have arrived at the emergency room, and I'm going to go ahead and give my report and drop this patient off with a provider of an equal or higher level of certification, and we'll be clear for the next one. This is our respiratory patient, this is our cardiac patient, this is our neurology patient, GI, GU, you name it. Anybody who has any medical complaint, we follow the same exact steps and we wind up wherever those led us. And really at the end of our secondary assessment, our OPQRST, our sampler, and our baseline vital signs, I'm going to have the choice of, do I have any other medicines that I can use to treat this patient? Well, our respiratory patient got oxygen during our primary assessment. So the only other thing I have left really to treat my respiratory patient is going to be albuterol. So if I follow my albuterol protocol, I will know by the time I'm finished here, can I give this patient albuterol? Can I not give this patient albuterol? And if you can't provide them with their albuterol because they've already maxed out their dose or they don't have a prescription for it, what's left to do but transport and reassess?
Nothing.
Yeah, nothing. We just transport them to the ER and we reassess and complete our focused assessment, and we've treated our respiratory patient appropriately. And really at the end of the day, that's what we're looking to do. Make sure we provide the best care possible for our patient, and we're not really fixing their emphysema or their COPD or their asthma or their chronic bronchitis or pneumonia or any of the other things that can attack their respiratory system. We're not going to knock out their hypoxic drive. Asthma is the drug that I can use to treat my respiratory patient's problem. So I'm going to treat my respiratory patient's problem with oxygen right off the bat, first line treatment. From there, I'll figure out, can I provide them something else, or do I just provide them with another treatment, which is transport?
Anaphylactic shock. I
So
thought of
for
him
the
immediately.
absolute life of me, I can't remember what that movie is.
Hitch.
That was Hitch? Okay.
Yeah.
Because I've done this lecture a million times and absolutely unable to remember what that movie was. And he's been in so much stuff that it was impossible to find. All right, so we're going to talk physiology about allergies and anaphylaxis. We're going to talk about the differences between a mild localized reaction and anaphylaxis. We'll talk about a term called anaphylactoid and how that differs from anaphylaxis. And then we're going to talk about epinephrine. Epinephrine we have beaten up quite a bit, but we are going to talk about it some more just to make sure that we know the indications, we know what we can expect as far as a reaction to the drug, and really kind of get into the nuts and bolts a little bit deeper about how this drug has actually worked. So let's talk allergic reaction here for just a moment. Making sure I have my screen up correctly again. So our body is going to have an allergic reaction when it is exposed to something called an allergen. An allergen is something that when introduced to the body, it triggers the immune system to respond. The immune system is floating around trying to identify things as either self and part of our person, or not self. When it identifies something as not self, it is going to stimulate that immune system to respond and go off and destroy whatever that invader is. When we have an allergen that triggers anaphylaxis introduced into our person, it triggers that response systemically. Anaphylaxis is really a systemic reaction. That's why when you heard that doctor talking about having at least 2 body systems involved, that kid had GI compromise because when that allergen got into him, it made him vomit. He had the angioedema in the skin reaction. He had swelling, he had itchiness, and he was having a respiratory component as well. That's how we tell a reaction is actually systemic and actually spread throughout the entire body versus when it is just localized. When you're stung by a bee, you're going to have a localized reaction to that. Your immune system's going to identify that venom, that toxin, and send off some inflammation, send off some white blood cells. It's in an effort to contain and kill that invading organism right there at the site of the exposure. So you may see some swelling or some itchiness or some skin changes. So we'll start to see that urticaria that the doctor mentioned, some of those hives and itchiness. But what generally doesn't happen to you if you get stung by a bee and you're not, quote unquote, allergic to it? Does it progress? Does it get to the point where it starts taking out your airway, starts taking out your breathing, starts taking out your circulation, causes GI upset?
No.
You get a lump.
Yeah, it stays right in that one spot, and we don't have this big overreaction freak out from the immune system starting to take out all of our vital functions, starting to cause hypotension, tachypnea, respiratory distress, swelling in the airway, swelling in that angioedema places. So you'll see some pictures coming up that are great examples of angioedema. What can we be allergic to? Well, the short answer to that is just about anything. We can have allergens caused by organic materials, foods, medicines, chemicals, venoms, and toxins. Really any type of thing that can be introduced into our body that is not part of our human can cause us to have an allergic reaction. I watched a show with my wife. I forget what the name of it was, but it was these people who kept like all sorts of rare and exotic and dangerous pets in their homes. So the people had lions and tigers, and people had like the most venomous snakes that are known to mankind. And most of the time when these people were bitten by those snakes, you know what killed them? It wasn't the venom. It was the fact that their body had developed an anaphylactic reaction to that venom. And anaphylaxis is what killed those people most of the time. So let's talk about allergens in organic materials. Organic materials are what we think of as our normal like seasonal allergies, or things like dust or mold in the house. You can have an allergy to poison ivy. Poison ivy is an allergic reaction when you break out and get itchy and get that sort of weepy, gross skin. Rarely do these cause that systemic anaphylaxis response, but it is an allergy when you break out in those itchy splotches from poison ivy. It is an allergy when pollen in the springtime and in the fall make you sneeze. Dust making you sneezy and making your eyes itchy and watery is an allergy. Next, we'll move on to food. Food causes about 30% of the anaphylaxis deaths all the time. Food, a lot of times, like we saw with the kid in that video, can take a little bit longer to appear, and they can take a little bit longer to go away. Because once you've gotten that food down into your system, sure, EMS, if you listened to the doctor giving a report and talking with his colleagues, EMS gave 2 epinephrine injections on scene. And then an hour later, the doc was giving another epinephrine injection because they would get better for a little while. That epinephrine would do its job. And then the food that was still inside that kid's system would break down a little bit more. The proteins of the fish that he was allergic to would get out into his bloodstream. And then what happened?
It would wear off.
Yeah, the food would outlast the epinephrine would wear off, and anaphylaxis would come back. Food allergies can be very, very severe and significant. And realistically speaking, you can be allergic to just about anything. Some of the big ones that we always think about are the peanuts and the shellfish. Peanuts and shellfish are very, very high risk anaphylaxis allergies. And there's peanuts involved in so many things, and peanut oil and peanut dust in so much of the food that we're exposed to that it is hard to stay away from. Shellfish is another big one. Shellfish a lot of the times will have a cross allergy with certain medications like the dye that they may inject into you to do a CT scan or an MRI, some cardiac meds. Some shellfish is in a lot of things, sort of sneaky shellfish that you wouldn't even think of. And it can cause a true, real for life, life-threatening emergency.
Never heard of anybody allergic to corn.
Yeah, and some of the stuff, again, think of allergy versus sensitivity versus anaphylaxis. Some of this stuff you can be allergic to or quote allergic to, like when we talked aspirin, when we went over pharmacology. It's not a true real for life allergen. It's not a true real for life allergy. It just makes you ill when you eat it or expose your body to it, or it causes an increased sensitivity. Are you really in danger necessarily of going into anaphylaxis? No, probably not. That's why I said your patient, when you ask them if they're allergic to aspirin and they say yes, you ask them, all right, what happens to you when you take aspirin? When we get into signs and symptoms of anaphylaxis here in just a couple of minutes, if their aspirin allergy doesn't trigger one of those things, that's probably one of those times I might get on the phone with medical control and say, hey, listen, they report an aspirin allergy, but this is what happens to them when they take it. And we're trying to now measure good versus bad, harm versus help. You can have an allergic reaction to any type of medication. It can occur from any route of administration. Generally, medications that get injected into a person lead to a more sudden onset. So PO meds will take a little bit longer, PO meaning by mouth. The onset of medications that your patient's going to put into themselves by mouth will generally take a little bit longer because, first of all, your stomach acid has to break that medicine down. Secondly, on top of having to break that medicine down, it will also have to build up in your system. My wife developed a later in life allergy to the psyllin family of medicines, and it wasn't until day 9 of a 10-day course of antibiotics that she realized she was allergic to it. She woke me up after an overnight shift, and she was hives and angioedema from head to toe. Her being a medical person and being an EMT said in very certain terms that I was not taking her to the emergency room and I needed to figure out a way to deal with this in the house. Didn't want an EpiPen, didn't want an ER, so I gave her enough Benadryl to kill a buffalo, and she slept for the next day and a half, and she was better when she woke up. But I wanted to stick her with an EpiPen and bring her to the emergency room because she had airway compromise. She was sort of had that dry, kind of wheezy cough that you could hear from that child. She was head to toe hives, didn't feel well, and really was borderline at best. to be stuck with an EpiPen and go to the emergency room. But I figured it wasn't worth the trouble I would get myself into. So we figured out a way to deal with it at home. But any medicine at all, and a lot of medicines, you'll be allergic to every one of them in this particular family of drug. And we're still looking for the same signs and symptoms, that urticaria, that GI upset, that angioedema, some respiratory issues. The more things you stack up in the negative category when we start looking at anaphylaxis, the more likely it is to really be a true for life, life-threatening emergency with some systemic problems and some systemic response. Chemicals for sure. I personally have a contact allergy with latex. So if I would have put on the old style latex gloves that we used to carry, I could leave fingerprints on my arm. I could write my name in latex dust on my arm and would break out in a rash. But they can be severe and they get worse the more your patient is exposed to them. It can be minimal exposure, like just being in the same room with someone wearing perfume or makeup dust can cause some pretty significant reaction. I have a friend who years ago she worked in an office and she could only work off shifts when no one was around because she was deathly allergic to perfumes. And if you walked in or near her wearing perfume or cologne, she was going to have a difficult rest of her day, and up to and including needing epinephrine. Bees and hornets and wasps are from the Hymenoptera family. Those are typically some of the worst allergic reactions to bee stings. The venom enclosed in that bee is very, very negative for people who are allergic to bee stings. If you look at the venom sac and the venom gland, when a bee stings you, that is what gets left behind when they pull away. That stinger stays inside of you, and that venom sac and the nerves that control it stay in place and will continue to squeeze that venom into your person for up to the next 30 minutes. If we're going to remove a stinger that we find still in somebody, we want to be very careful on how we do that, because if you were to grasp hold of that venom sac with a thing like forceps or tweezers, you will actually inject the rest of that venom into your patient. So you're going to use something like a business card or a credit card or something that you can use to drag along the skin to actually pull that out rather than squeezing and grabbing a hold of it. You want to be very careful to not introduce any more of the allergen into your patient, because we're just going to make them worse at that point. So in the vein of common sense, let's talk localized reactions first. Our localized reactions aren't as concerning because it's not affecting the body as a whole. Histamine is released. It is a chemical used by the immune system to deal with whatever it is that the immune system is trying to fight off. Most of the time when we talk a localized reaction, we're going to look for visible signs on the skin or some GI upset. Histamine is also very, very prominent in your GI tract. We start to only have one problem, and they're much easier to manage because this is not going to be anaphylaxis. If we are just seeing one problem, we're probably not yet looking at an anaphylactic reaction. Urticaria, this is that hives that the doctor mentioned. Urticaria, they're sort of red, splotchy, raised patches. A lot of times they'll talk of itching or burning, which is why the doctor was remarking at that kid scratching himself, because it's an itch that just doesn't go away. You scratch and scratch and scratch and scratch and scratch, and that itch just continues. This is what I was talking about with my latex allergy. I could do this. Probably not anymore because we haven't used latex gloves in a long, long time. So my allergy, my localized reaction to it has probably improved some, but I could make this happen if I wanted to.
It's kind of cool.
Yeah, and what I'll tell you, you itch like a dog. It is just miserable. And of course, you have that latex glove on, right? So you get itchy and you use that latex glove to scratch the spot that's itchy, and you're just exposing that area to more of the allergen and making it itchier, and that scratch is just never satisfied.
But it just itches, right? It like doesn't do more than just itch, or does your throat get kind of?
So this, we're still talking localized reaction. We're
Oh,
still
okay.
talking just an allergic reaction, not anaphylaxis. When we talk anaphylaxis, you'll see sort of the difference, because this might be involved in anaphylaxis. But when we're talking just strictly allergen and allergic response and a normal allergic response and a localized reaction, we would see just this. Here's some more examples of urticaria. And if you look at this sort of red area right here, that looks a little angrier and a little bit more inflamed because the patient's probably been scratching at it. Next, we'll get into the GI symptoms. That histamine is being produced and helping to produce stomach acid. So our GI system will still possibly become sort of upset with a big histamine release. Some of the GI complaints that our patient may have would be some cramping or some pain in their abdomen, some nausea, maybe some vomiting, some buildup of stomach acid. So they may complain of some heartburn-like symptoms or some diarrhea. But we're talking one-offs here. We're going to have just one problem. A localized reaction generally requires very little intervention from us. Remove the stinger, try and remove the source of allergic reaction if you can. And our patient care is going to be supportive in nature. So if there's something painful, we apply some ice to it. If there's some swelling, we can apply some ice to that. And we're going to monitor to make sure that this reaction isn't getting worse and isn't progressing into a more systemic nature and doesn't start to look like an anaphylactic reaction. We just monitor to make sure that the onset isn't more gradual and doesn't turn into anaphylaxis right in front of us. Anaphylaxis is a true real for life emergent situation. This is extreme, it is life-threatening, it is a systemic reaction to all of the same things that we just talked about that may include up to and including shock, respiratory failure, cardiac arrest. It involves multiple body systems, it touches all of the important things, and histamine is going to be one of the big things that causes a lot of this issue. Now, when we're talking about our patient with that hives, that urticaria, instead of being in that localized spot where the patient wrote skin writing on themselves or wherever that bee sting is, we will see hives and urticaria throughout most of or all of my patient's body. So let's talk about this in terms of our assessment. When I'm doing my ABCs, my primary assessment, and I'm listening and looking at my patient's chest, I'll probably start to hear some of the changes in my patient's lung sounds. I will probably see this urticaria spreading throughout my patient's body. If I'm going to expose my patient to check their skin color, temperature, and condition appropriately, I will see this rash, this hives, spread just about to the everywhere. Remember I said, if it looks like a duck and it quacks like a duck, it's probably not a turkey. Now we start to couple that assessment with my patient complaining of some persistent nausea, vomiting, diarrhea, abdominal pains that are continuing to get worse and get worse and get worse. And now we'll talk some more of what's going on with our anaphylaxis patient, because that histamine release and that body encountering and sending off all these chemical mediators and these cytokines and the immune system to go off and deal with that invader cause vasodilation. And I'm talking whole scale vasodilation. The blood vessels are going to rush blood to the bad thing. And that's why they're dilating. But if we're talking a systemic reaction, where's the bad thing? It's one of the last words on the slide. That bad thing is being picked up and transported everywhere. So that's why we have that whole scale vasodilation. We have all of that histamine going everywhere. We have blood vessels that are becoming leaky in an effort to get more blood rushed to get this bad thing out. And all of these things are causing the body to have a negative reaction to something that it does all the time, and really triggering our anaphylaxis and our anaphylactic shock. We start to see that angioedema. If all of these blood vessels are dilating and becoming leaky and they're spilling contents out into the tissues are going to start to swell. We'll see mucous membranes around the eyes and the lips and the tongue and the airway all starting to swell. Our patient's tongue's going to look twice the size that it should be because it's twice the size that it should be. Our patient's lips are going to start to swell and become inflamed and angry looking. We'll start to see some signs of respiratory distress because we have swelling in the lower portions of the airway, and we have edema or fluid in the lower portions of the airway, because to go hand in hand with all that vasodilation and the swelling, we have leaky capillaries, and those leaky capillaries are just going to make things sound wheezy or stridorous and wet. We're going to have some significant dyspnea. So are we starting to put together the reasons why when an allergic reaction goes systemic, it presents kind of the same way? But if only one of these things was happening, our patient would be able to live pretty well, right? If we were only having a little bit of respiratory distress, that's an easy fix. If we were only having a little bit of GI upset, that would be a pretty easy fix. But we are now having all of these things all at the same time, and it was triggered and stimulated by the body itself. So this really is a situation where the body is actively trying to kill itself on multiple fronts. Let's see how this wheezing sound plays. So we have inhale, exhale wheezes. So we start to hear that adventitious lung sound we talked about just a little bit ago. Now we'll try and play some stridor.
Hello, it's Wes, Super Wes that is. In this video, I want to discuss stridor. Stridor is caused by narrowing or obstruction of the upper airway. Stridor is wheezing, but it's usually heard during the inspiratory phase. Whereas in this diagram, this is the inspiratory phase and this is the expiratory phase. These little lines denote wheezes. So during inspiration,
Okay, I don't like that guy. So with all of the swelling and all of the leakiness and all of the everything inside this patient going wrong, we have a very tenuous airway. We don't have an airway that we can describe as patent, because that airway can swell to the point where it is completely closed at any minute. How do we treat it? Just like anybody else, we're going to focus on our ABCs, our airway, breathing, circulation. If we have an airway problem because of that angioedema, that can and is likely to actually occlude this airway, and we have a patient who is tachypneic, so breathing really fast, because they can't get good airflow through all of those constricted and flooded airways. And we have a patient who is profoundly hypotensive due to all of that systemic vasodilation. And we have a patient who's experiencing some GI symptoms. Does it stand to reason that this patient is really pretty ill? And we have something that can fix it. First things first, if we are concentrating on our ABCs and we are seeing some respiratory distress and some signs and symptoms of shock, we're going to go ahead and treat this patient with some oxygen, lots of oxygen. Because when we talked yesterday about shock, what is the real true for life problem with shock?
Lack of oxygen.
Yeah, so it's going to be an oxygen delivery problem and a CO2 removal problem, which is just the part of the cascade of problems. So we're going to oxygenate this patient. And then we're going to start talking about our EpiPen. Epi auto-injector, our pediatric patient, so a patient who's over the age of 6 months, but under the weight of 60 pounds or 25 kilos, is going to get an EpiPen Junior. 0.15 milligrams in the lateral aspect of the thigh, held for 10 seconds, and then massaged to aid in the absorption of that medicine. Our EpiPen regular strength or our EpiPen adult is going to be 0.3 milligrams. Same, lateral aspect of the thigh, held for 10 seconds. And then we're going to go ahead and massage that area. But regardless of how big and how important this emergency is, we're going to go ahead and verify all of our patient rights. I read an article this morning when I got to work, and it was about some guy who was like 90 years old, who in 4 hours received 2 COVID vaccines and nearly died because he went into shock because they walked into the place. He went and was brought somewhere for the first injection, the one he was supposed to get. And then someone who was providing vaccines for the county, or I don't recall all the goings into, but they walked in and said, "Hey, I'm here for Bob's COVID injection." And they said, "Oh, okay, Bob's in room 2. Not thinking that, hey, there might be more than one Bob on that floor or in that facility. They just walked down to room 2, didn't verify they had the right patient, and stuck Bob with a second COVID injection within 4 hours, and the guy almost died. So going through our patient rights is going to actually be a thing that is really important, because verifying that we have the right patient, the right route, the right medication, the right dose, the right time, and the right indications is something that we can't skip.
Now with the EpiPens, I take an auto injector for something else, and when I press it against my thigh, it clicks that I know the needle's going. Well, I feel it too, but you hold it there until it clicks again, which is the needle retracting. Do the EpiPens do that as well, or no?
So the EpiPen really only clicks once.
Okay.
And we're going to play with the auto injectors a little bit today when we come in. We'll probably talk a little bit of check and inject too, because that's something that EMTs in the state of Massachusetts are becoming more familiar with and more accepted to actually do, is draw up medicine and inject it into a patient. So there's a couple of extra little bits and pieces and steps that we'll go through to make sure that we are drawing the right amount of medicine, because an auto injector is just that. It's automatic. You push it against that patient's leg, it's going to deliver that 0.3 milligrams of epinephrine 1 to 1,000. That's the concentration. If we actually now go and draw that medicine up instead, we have to make sure first that we have epinephrine in the correct concentration. We have to make sure that we draw the right amount. We have to make sure that our equipment is correct. That shows us that the 0.3 mLs of our 0.3 milligrams are going to equal out to the same thing. And we'll probably do that today when you guys first come in, and then we'll play around with some stuff. We'll do some more case studies. We'll do some working on station 3B, and that'll be at 1 o'clock when you guys get here. And your lecture for today